Good morning, everyone. I'm Liz Siegert, AHCJ's core topic leader for aging. I'm delighted to kick off this important conference on mental health with our first stellar panel, who will discuss what the pandemic
I'm going the wrong way.
taught us about the importance of social connectedness among older adults. Social isolation and loneliness among older people were already challenges well before the pandemic hit. COVID-19 just made it all that much worse. We all probably know someone, a parent, a grandparent, a neighbor, who became a virtual shut-in for much of 2020, losing that in-person contact with friends, family, and acquaintances. Some older people describe the isolation and inability to connect with others as a fate worse than death. Even now, some older people are still hesitant to gather in groups or with friends or go out. And while understandable, this interaction is vital to seniors' mental health as well as their physical well-being. Why are these connections so important? And what is being done to address them? What stories should journalists be focusing on when reporting on this topic? Here to inform us are four experts. Deborah Marin, MD, a professor of psychiatry, associate professor, geriatrics and palliative medicine, and director of the Center for Stress, Resilience, and Personal Growth at the Icahn School of Medicine at Mount Sinai Health System in New York. Namki Choi, PhD, professor and chair in gerontology at the School of Social Work, University of Texas, Austin. Kazli Killam, founder of Social Health Lab, San Francisco. And Paolo Narcisco, vice president of product and program development at the AARP Foundation. As usual, we'll hold questions to the end. Please type them in the chat box and we'll get to as many as possible. Please remember too, our presenters have agreed to hang around in breakout rooms following the panel, so you can speak with them further after the session has ended. And now I'll turn it over to Dr. Marin.
Thank you so much, Liz. Good morning, everybody. It's a pleasure to be on the panel. I'm just going to open up my app now, and my slides are there, correct? Okay, actually, let's go back for a second. Okay, I'm just going to use the app. So before I talk about social isolation, we can't talk about it in isolation, quite frankly. There's a larger picture I'd like to put this in context of. And the first slide here is a slide I think a lot of folks have seen, which has to do with what is the effect of trauma on people. And people have a different trajectory. Frequently, this is considered about disasters, but it also can be any kind of traumatic experience. You can see there are different ways people can go. The more somebody in the y-axis, the more somebody's affected by the trauma, the more likely they are to actually develop some behavioral health consequences, some stress-related reaction. Some people may not react at all at the beginning and then get worse at the end. Usually people react very well at the beginning. They feel stable, they can understand, be thankful for something, they may get better. Our goal, of course, is for people to completely recover from whatever the event is and be resilient, and the different paths toward that. This also is a slide I suspect you folks have seen, which has to do with how people respond to trauma. I bring this up because we all know in different parts of the country had different months when this occurred. There's a rapid ramping up, people doing well, then they get tired, they feel burnt out, if you will, whatever they're doing, and there's a hope for recovery. I hope that we are now actually in certain parts of the country in an area where we can consider recovery, understanding that there are many vicissitudes that can permit that to happen. So can you give me 1 second, please? Okay. I apologize. So the first thing is, what are stress-related disorders? I know all you folks know it, but when you look at it in the big picture, it all makes sense, correct? There is post-traumatic stress or acute stress reactions, mood disorders, particularly major depression, anxiety disorders, sleep disorders, and substance use. Sorry, a moment. I'm getting used to these slides looking at it this way. Okay, give me 1 moment again. I apologize. Okay. So what are the behavioral health consequences of the pandemic? As Liz mentioned, only so many things you can talk about, but the reason I bring this up is that we are kind of at a health crisis situation, if you will. We know that the general population has been severely affected. We know that actually younger people are more affected than others. We also understand that there are issues about actually COVID-19. When compared to other health-related conditions, including influenza and pneumonia, a very important study demonstrated that those who experience COVID-19 are twice as likely to develop some behavioral health or neuropsychiatric disturbance. Given the large number of folks who have the illness and who are now considered long haulers of long COVID, that's a public health concern we can't ignore. Okay. So what's the impact on older adults? Individuals over 65 are at most risk for both medical and neuropsychiatric sequelae. The loss of friends and relatives places these folks and these survivors at increased risk for grief and depression. I can't think of anybody I don't know who is in my age range, which is this age range, that hasn't lost somebody. The issue here is that for people who have caregivers to take care of them, and if their caregivers are depressed or anxious, that will have an impact on the ability of the older adult actually to thrive and be connected. Also, there are folks who've had paid caregivers who weren't able to be with them and have been isolating or can't work anymore. That also promotes social isolation and has to be considered. So I'm sorry, I'm looking at two screens right now. That's why it's a little difficult for me to look at my screen and see the small screen there. That's what the issue is for me right now. I apologize. Give me 1 second. Okay, I'm just gonna move this over to another screen for me. Okay. So we talked about the impact of older adults. Now I want to get to the point of social isolation. So social isolation has both an objective and a subjective component. Objective is how many times somebody speaks with somebody, talked with somebody, went to someplace. But people who feel physically that way may not feel subjectively social isolation. So we have to make sure when we talk about it, what's important is what the person's experience of it is. We should not make a decision about whether or not somebody's experiencing the loneliness of social isolation. Some people actually do fine with that. Okay. So what are the risk factors for social isolation? Personal loss, which clearly was a lot in the pandemic. Also, income loss is a big issue. And the other issues that really are important is that when people become older, and many of the workforce who are older are thriving and doing fine. So we're not talking about the vast majority of seniors who are okay and thriving. We're talking about folks who may have developed medical problems and are less able to move around, decreased mobility, decreased ability of transportation for them. And also people live in a community that they feel unsafe in. They may be less likely to go ahead and engage in activities. And the internet access, which I know is going to be discussed later, is not a negligible issue. While we know about 50% of seniors use the internet, a lot of folks, particularly in marginalized communities, have limited access to it for several reasons, including where they live. So social isolation has been declared by some people as a national emergency. You know, anywhere between 10 and 43% of older adults experience social isolation and loneliness. And as our aging population gets older, we know 10,000 people every day go into the age of 65 and above. We have to consider this as a growing issue. So when we talk about social isolation, there are ways that people measure it. They measure it based upon actually where they live, if they're rural versus in a city, if you will, whether or not they've got access to transportation, whether or not they have social support, either perceived or real. Marital status is a good example, being widowed or divorced, and also the social capital. I bring this up because when we talk a lot about isolation, you have to look at it in the context of the community in which the person has access to. Are there resources in the community for them? Do they have access to education? Do they have access to community centers? Do they have access to faith-based organizations? Access to good food? All these things matter. So, all right, we talked about behavioral consequences of stress. Behavioral consequences of social isolation are the same, which tells you that social isolation is a stressor. Just the act of being isolated for a period of time, let alone quarantine, for example, puts people at increased risk of all the illnesses I talked about. Also, dementia. It's considered, we talk a lot about mental health, but dementia is a neuropsychiatric diagnosis. And I am a geriatric psychiatrist, so I deal a lot with this. And this cognitive ability to impairment is very important. Our brains really need to be challenged to thrive. The whole idea of a brain being static is way gone for decades. Our brains are plastic, and we need actually for neuron development to have our brains function and be teased. Now, I bring up the medical consequences of social isolation because these illnesses as well put people at risk for problems. There's a strong relationship between cardiovascular illness and depression, for example. This is important. If people don't get their medical care, they're more likely to have behavioral consequences of the medical treatments they're not availing themselves of. So we know about all the reasons why people may be isolated. Things are opening up now, and now I think we have to focus on what can be done to deal with this issue. Okay. The neurobiological basis of social connectivity, I cannot stress it enough. Of all the things that people do well with in terms of their mood, in terms of their resilience, and we'll talk about it in a moment, is the ability to be connected to others. We thrive on congregating in one form or another. Thank goodness we do have the ability to have this kind of meeting, for example, to congregate. We could have done that a few years ago. That connectivity is really critical. It doesn't have to be in person. It helps, but it doesn't have to be. We also know that social connectivity has been proven in many disasters to be very helpful. Combat veterans can say that if they're connected, they do better, they don't develop PTSD as frequently. We know survivors of hurricanes or Sandy, for example, on the East Coast, people and communities in which there was connectivity definitely rebounded better. So the role of resilience. We all know resilience is the ability to bounce back. We have to remember that older adults often actually can be quite resilient. They've been through a lot. The question is, has their resilience been tested to the point that it's not an on-off switch? Resilience can occur and be promoted throughout life. Maybe born with certain genetic predispositions, but there's so many issues about community, education, social support that really help promote it. So what does it mean to be an individual that's resilient? Cognitive flexibility, ability to rethink of what a problem is, including being alone. Facing fears, the ability to discuss how one is fearful is very important. Avoiding discussion how one is fearful about being alone, for example, does not help the person think of a way to solve the problem. Following one's moral compass, feeling that what they did in the pandemic, albeit may be limited because they couldn't do everything they wanted, but they know that they did something to give them meaning and purpose. This really helps promote resilience. And having meaning and purpose is important for older adults. This is where social connectivity comes in, particularly with family. If this has been challenged, and it has been in the pandemic, and I heard my panelists talking about it, and I'm a grandmother, I could relate to this, it's very important to try to reconsider what does give you meaning and purpose in spite of the issues that you have been going through. And then there's the issue of the family. One thing that's important, I think, for social connectivity is for seniors to feel that it's okay to ask for help. It also turns out that if you give help to others, altruism helps actually people feel better about themselves and give them meaning and purpose. And this has, again, back to the community. Is the community resilient? Can they tap into what their community offers to help them weather the storm? And we're beyond COVID-19 right now. We're talking about a larger issue in general about connectivity. Okay. So in terms of what people can do about it, I just want to go to the next slide, please. Okay. So independent of COVID-19, we have to remember that the illnesses I've been discussing are highly treatable. They respond well to medication. They respond well to therapy. And the treatments across the different illnesses are very similar. The challenge often, however, is access to care. And most mental health is actually provided, as you know, by primary care. It's very important for older adults to let their clinician know that they may be depressed. 2 questions. Have you lost interest in things over the past couple of weeks? Do you not enjoy things as much as you move in depressed? It's actually a quality indicator for primary care physicians to ask that question. It's not always asked. People should not feel shameful to be this depressed. And you can't muscle your way through a major depression. It doesn't work that way. It's a biological condition that should be treated. The same is true for stress-related disorders, insomnia with cognitive behavioral therapy. And I think for older adults, they may feel that if you say this, you're a sign of weakness. People can be very resilient and suffer. I can't stress that enough. Now, at Mount Sinai, we actually have developed a treatment pattern. We're self-insured, we're 40,000 employees, and we actually developed a treatment service. Both our dean and our CEO are psychiatrists. It was not hard to make this happen, actually. I bring it up because making access to people who are working, for example, people in the workforce, easily get access to care is very important. We also run resilience workshops, and I'll talk about that in a moment. Resilience can be promoted. If these workshops can be run by peer leaders, it doesn't have to be run by specialty folks, as long as they understand how to promote resilience. And we've run almost 200 workshops now with hundreds of employees. And also we were able to create a situation that at no cost actually for our workers to see us. So I bring this up because I think we're not unique, but I think it's a model that should be considered. Cost is a big issue for access to mental health, and destigmatization is a critical issue that needs to be done in the community, in the workforce, any organization I could think of. That's a key factor here. The last slide I'm showing here is actually, we work with churches in our community. It's just an example of how one can go into the community and help folks actually feel that they can become more resilient in workshops. We've trained actually over 70 community health advisors, congregants in 16 churches to teach about mental health, to teach about cardiovascular disease. And we got funded from actually Robin Hood Foundation to actually run our workshops, which you can see here what they are, with the community. And the reason I bring it up is that anything that a community can avail themselves of by experts, for example, to train people who are local. They don't have to be a psychiatrist, psychologist, to do this, to understand. So each of the workshops actually deal, for example, building your circle, social support, finding meaning and purpose. We also talk about social justice because we can't ignore the fact that the disparity in access to care and the disparity in the impact of COVID in the underserved and marginalized communities is devastating and needs to be addressed as well. My last slide actually is on a positive note, which is a post-traumatic growth. We always talk, I'm a psychiatrist, we talk about pathology. It only was about 30 years ago, people said, maybe something about resilience and strength to think about here. People can grow from this situation. It's very challenging, obviously, but what is post-traumatic growth about? It's about the ability to say, wow, I weathered it. I got through it. I may be changed, but I got through it. Relating to others, I found a new way to communicate. I now know how to use Zoom with my grandchildren. I actually reached out to my friends from college. What a great thing. I didn't think about doing that. Also realizing that one has meaning in life in spite of all the challenges and the new possibilities. I mean, it's been a devastating situation. However, I do think that one has to think about the optimistic view realistically about how we can manage this as well. Thank you.
Thank you, Dr. Marin. That was really interesting and I think really set the stage well for the rest of our presenters. Next, we have Dr. Namki Choi, who's a professor at the University of Texas, and she's going to talk about some of the ways research has shown we can help mitigate social isolation. Dr. Choi.
Thank you very much for inviting me to talk today. It's an honor. And I'm going to talk about the research that I've done for the past 12, 13 years on telehealth interventions for depression and social isolation among homebound older adults, mostly homebound and very low income home older adults. And I want to, it's not advancing. Please, next slides. So I specifically want to talk about 4 of my projects, and they were funded by the NIH and AARP foundations. And I also want to say that this is a very multidisciplinary project, so including social work, clinical psychology, geriatric psychiatry, public health, biostatistics, of course, nursing, and digital, techniques, development, and medicine too. So I really want to say thanks to all my team members. Next slide, please. And I want to also talk about the issues related to depression in homebound older adults. So homebound older adults tend to have 2 to 3 times higher rates of depression than compared to their mobile age peers. And most rely on antidepressant medications prescribed by their primary care physicians. And the problem is that these medications have limited effects, especially among low-income homebound older adults, because the medications do not teach them coping skills. And so preferred treatment is pharmacotherapy and psychotherapy combined. However, we also found that psychotherapy alone is very effective. There is no age group difference in terms of the effectiveness of psychotherapy. And another problem is that these homebound older adults are not well served by the existing systems of mental health because of multiple system and personal barriers. I think Dr. Marin talked a little bit about the personal barriers that a lot of homebound older adults and older adults in general have still, big kind of thing about stigma about mental illness, and they do not want to recognize, they do not want to talk about their depression. Multiple system barriers. One thing is like lack of transportations for these older adults to go to clinic-based psychotherapy. Another one is that we don't have enough people, therapists who can visit these older adults in their own homes to provide therapeutic interventions. So geriatric mental health workforce shortages are big, and we are not going to solve it in the next probably 20, 30 years. Simply, we don't have enough professional clinicians to help a growing number of older adults. So one solution is to train and deploy BSW, that's bachelor's in social work, or other BA level interventionists to be able to serve these older adults. And we also need to integrate mental health and aging services for improved access and acceptability, scalability, and sustainability. Right now, we have mental health, physical health, and aging services all kind of fragmented. However, if you integrate mental health services into aging services, the acceptability and accessibility will definitely increase. Next slide, please. So I'm going to talk about the evidence-based psychotherapy. Some of them I've used in my research projects. They are structured, short-term, very brief, and no digging up the past issues. A lot of older adults are really afraid, especially the people with a lot of trauma. They don't want to dig up the past, and that's not effective either. And we don't do any psychoanalysis, but we focus on here and now and moving forward. And one of them that I've used is problem-solving therapy, PST, which provides rational versus emotional problem-solving and stress coping skills training to these older adults. It worked very, very well. And the second one that I've used is behavior activation, It's really helping older adults to have more structure in their daily life by planning and engaging in activities to accomplish the goals that align with their values and beliefs in chosen life areas. Next slide, please. So the first project that I implemented, it was well before COVID, and I wanted to really try the tele-delivery of these psychotherapies for homebound older adults. So we tested the comparative effectiveness of tele-PST. At that time, we used Skype. It was free. It was, deemed very secure according to the University of Texas Information Security Office. And we compared it to in-person PST. And attention control is just telephone support calls by our research assistants to control for interaction effects. So both tele-PST and in-person PST were delivered by licensed master's level professional and clinicians in there. And we included 158 people aged 50 and 58% were Black or Hispanic. We included age 50, and even the NIH reviewers asked, age 50, that's not geriatric population. But if you look at very low income disabled individuals, age 50 is a real important mark, because they tend to have more depression. Yes, they are younger than age 65. The kind of chronological age is not a good indication of these people's health health problems in there. So we've seen actually those people in their 50s benefit far more than those in their 60s from our program. Next slide, please. So the outcomes of this tele versus in-person PST has been published. And then you can see in the graph in there, the blue line is tele, and the red line is in-person PST. And both tele and in-person PST were very effective in reducing depressive symptoms, 10 points plus score reduction. However, tele-PST had more longer term effects, and they were doing much better actually after 6 months. And we did not really focus on disability per se, but disability is so interconnected with depression. So we looked at the depression and the disability outcomes, and then we found the same. Tele-PST had much more longer term effects than in-person PST in reducing the disability. And we'll talk more about that, why that must have been the case. So next slide, please. So we also looked at the emergency department visit among our participants. And we compared the 6 months prior to treatment participation and 6 months after treatment participation. You can see in the red number in there, prior to treatment participation, 21.4% had reported 3 to 9 ED visits. After treatment, only 7.5% reported the 3 to 8 visits to ED. And ED visit frequencies at both times were significantly positively associated with depression symptom scores, of course. Next slide, please. So that project led to a bigger project. So this was between 2015 and 2019, and then 2020 we spent data, analysis and publishing the outcomes in there. So in this study, we focused on testing real-world comparative effectiveness and sustainability and scalability for improving access to depression treatment. So my focus is always improving access. How do we really make the mental health services available and accessible to these very low-income homebound older adults? So the first condition in the randomized clinical trial was tele-BA, the behavior activation by lay counselors. And we compared the effectiveness of the lay counselor provided depression treatment to tele-PST by licensed mental health clinicians. So in most states, you cannot provide the psychotherapy unless you are licensed mental health clinicians. So our lay counselors could not provide PSD. So we have to have tele-BA, behavior activation, which is treatment, not psychotherapy. It's not termed psychotherapy. And of course, we had the attention control group. And all 5 sessions were delivered via HIPAA compliant video conferencing platform. And all interventionists at this time were embedded in Meals on Wheels. It's a large Meals on Wheels in Central Texas agency for care coordination with case managers. You cannot just provide depression treatment and expect to see positive outcomes for low-income homebound older adults because they have other social and healthcare needs. And case management is really important, and care coordination with these case managers are really important. So we included 277 individuals age 50 plus, and 59% were Black or Hispanic. Next slide, please. So we can really show in here the handouts. The first handouts to our clients are to kind of explain the body and mind or the healthy behavior and improve mood connections. So in our colorful handouts, we emphasize that if you increase healthy behaviors and decrease depressive behaviors, you will have positive experience, which will in turn lead to improved thoughts and mood. Next slide, please. We also provide this handout. It's called Life Areas and Values. We list the areas of life the older adults may want to focus on and what are their values. Based on these, the older adults choose to select their goals and activity plans to accomplish their goals. And these are really important because this is a client-directed or person-centered approach, and our counselors are there to support and provide any guidance when the clients need it. So next slide, please. So I show you in here our telesessions. There is our bilingual provider, Julieta, showing the life areas and values sheet. And then there is our clients, and the green folder includes all our handouts that we deliver to our clients in there. So next slide, please. So the outcomes of this study was published in JMA Network last August. And as you can see in here, again, the blue is tele-PSD and orange is tele-BA. And as we hypothesized in terms of the depression score outcomes, the clinician provided tele-PSD was a little better. So the effect size for tele-PSD was 1.0, and effect size for tele-BA by the lay counselor was 0.62. 0.62 is a really impressive effect size. However, in terms of the disability outcomes, and then social engagement and activity outcomes, and also their satisfaction with the participation of, their participation in social roles outcomes, there was virtually no difference between the lay provider, provided tele-BA and clinician provided tele-PSD. So it really shows that tele-BA by lay providers are, important and effective. Next slide, please. So next project was we took this tele-BA by lay counselors or lay providers to see if we can reduce loneliness. Our title, includes improving social connectedness because we want to emphasize the positive. So in this study, Dr. Marty Bruce Dartmouth was the PI, overall PI, and I was the Texas site PI. And we tested comparative effectiveness of tele-BA versus tele-friendly visit. And we included homebound older adults in New Hampshire and Texas. And we provided 5 sessions of tele-BA or tele-friendly visit. And we measured 6 and 12-week and 12-month outcomes. And we were really kind of pleased to see that the positive impact of tele-BA compared to tele-friendly visit was evident in decreasing loneliness, depressive symptoms, and increasing social interactions at all 6 and 12-week and 12-month outcomes. So 12 months is really showing that there is a sustaining effect, positive effect of the tele-BA by lay counselors. Next slide, please. So we have published the outcomes in the American Journal of Geriatric Psychiatry. So improving social connectedness for homebound older adults, and was a randomized clinical trial of tele-BA versus tele-friendly visit. Next slide, please. While we were implementing these studies, of course, we faced some challenges for tele-delivery, especially for low-income homebound older adults. The most challenge is high internet subscription fee and other digital divide. So most of them didn't have, prior to COVID, most of them didn't have the internet subscription. They could not afford it, and they didn't have computer or a tablet. So we had to purchase Wi-Fi enabled laptops or iPads and loaned the equipment to people who are participating in our programs. And also rural areas, the connection was not sometimes good. So we had to really work hard to make the tele-delivery possible. And we found out that actually, how do we really reduce the digital divide gap? And if you look at the 2006 Reauthorization of Older Americans Act, it provides funding to directly deliver mental health services or purchase services in aging service agencies. And we've talked to Texas State, personnel for OAA, and they would be happy to really use the fund in there. Another one is, of course, the reimbursement. First of all, the lay counselor services are not reimbursable under Medicare or Medicaid, but also even with the licensed clinicians, in-home tele health services needs to be covered by Medicare and Medicaid beyond the COVID-19. So that would be the one that we should work on. Next slide, please. So we also found out that among very mobility impaired older adults, they had high rates of falls and fall injury and frequent use of EMS for lift assistance because they fell and they could not get up on their own. And fear of falls and falls are leading to further activity limitations. So this really affected the depression treatment outcomes. And we did some national data analysis showing reciprocal associations among falls, fall worries, and depression, and of course, increased healthcare cost. So we really thought that we need to integrate depression treatment and fall prevention. And as the first step, we conducted a feasibility study of fall prevention by lay coaches, including CDC steady fall prevention materials. And we used a really cute, the tablet-based exercise program. It's gamified one. Next slide, please. So this is called Koku. So it's like avatar comes out, blowing whistles, etc. Next slide, please. And there are many different activities that older adults can do using this iPad, gamified program. So the exercise intensity levels increase slowly to really, for older adults to move on. And there are some other ways to increase their diets for bone density and then home safety measures in there. Thank you. The next slide, please. And we also used pre-COVID, we used this digital device to measure the balance and gait, among older adults. And it's much safer than trying to use some of the testing kind of procedures to, include homebound older adults. Unfortunately, of course, during COVID, we had to stop because we could not do the safe social distancing with that. So in the future, we hope to be able to use it. Again, it's really simple stuff. It's a belt, goes into the person, etc. Next slide, please. So the feasibility study was published again. It's multi-component for prevention for homebound adults, facilitated by lay coaches and using tablet-based gamified exercise intervention. You can take a look at it if you are interested in. Next slide, please. So all these previous research led to our current project, which was funded in September. So we are really in the beginning stage of this. So this is going to be integrated tele-BA and fall prevention by lay coaches and counselors. So it's going to be 4 randomized clinical trial, tele-BA, of course, and fall prevention, and tele-BA combined with fall prevention and attention control, of course, the care course. And our enrollment goal, our enrollment goal is 320 people in the next 3.5 years. And we have so far completed tasks related to Spanish translation of the Koku, the exercise app, and it is available free at App Store. We released it like last week, and anybody can use it. The Koku, I wanna give credit to my colleagues at the University of Manchester, UK, who developed the Koku, and we were the first US entity to try the Koku with US homebound adults. And then we did the Spanish translation of that. And Koku has been, English version of Koku has been released in the Apple App Store for free during the COVID, so that more people can use it. And then we also kind of transitioned the in-person fall prevention into tele-delivered fall prevention because we don't know when this COVID is going to end. And then we also made more digital depression psychoeducation. So people, anybody can utilize this, for educating homebound adults or other adults. So that's it. Next slides. Any questions? I will take it later. Thank you.
Thank you, Dr. Troy. That was really interesting research. And I have questions. If nobody else does, I have lots of questions. And next, let's talk about some other practical things that are going on. And to start that side of the conversation off is Kathleen Killam from Social Health Labs. Kathleen.
Wonderful. Thank you so much, Liz. And it's great to be here with you all today. So like Liz said, I'm kind of going to step back and share an overview of the landscape of solutions that are emerging and accelerating due to the pandemic to really help connect disconnected older adults, as well as people of all ages. So a little bit about me quickly. I've spent the last 10 years studying and building initiatives around connection and community. I'm currently the founder of Social Health Labs, a nonprofit where our mission is to really catalyze innovative solutions and approaches to social well-being. I did my master's at the Harvard School of Public Health, where I actually focused on solutions for loneliness prior to the pandemic, a little bit before everyone was talking about this topic. And my background prior to that is in research in mental health and positive psychology, as well as healthcare innovation. And if you want to learn more, you can feel free to get in touch on my website. So in our time together, I'm going to first share kind of a high-level framework to help everyone conceptualize and get on the same page about how to think about even addressing widespread isolation and loneliness. Then I'm going to go through and share a ton of examples about real initiatives that are happening today in the US and around the world to really tackle this issue. And then finally, I'll make a note about resources and how you can get links to learn more about all the examples that I share. So with that, today's panel, the question we're all kind of tasked with answering today is what the pandemic teach us about the importance of social connection and aging. And I think that my answer to this question at the highest level is really that social connection is not a nice to have. It's essential to our health and well-being. And so we really need to think strategically about how to improve our social well-being in our society in kind of a comprehensive, systemic way. So to do that, it's important and valuable to kind of take action to support older adults who are already isolated and lonely, which you can kind of think of as downstream disconnection. But we also really need to make sure that we're preventing isolation and loneliness in the first place and really creating the conditions for connection and social well-being to be the norm. So what that requires is really kind of looking upstream behind the bend where the water is flowing from to really understand what are those environmental and systemic and underlying causes that are leading to people experiencing isolation and loneliness so regularly. So a helpful framework to actually go about this is the social ecological model, which is often used in public health and really helps to identify the different levels at which we can intervene to improve people's health and well-being. So this is everything from at the highest level, kind of thinking about policy and federal legislation that can help people to be more connected. Then if you zoom in a little bit and think about the community and kind of the cities and neighborhoods and the resources and social norms that exist in those places that are influencing people's relationships. Then we can go another level deeper and look at the institutions, right? All the businesses, the schools, the workplaces that people frequent on a regular basis and how those might be influencing people's ability to connect. Then taking it a level deeper, we can look at the interpersonal level and think about how people's friends, family, social networks are supporting their social well-being. And then finally, down to the individual level, we can think about ways that we can improve people's knowledge, attitudes, skills, and behaviors to help them lead meaningfully connected lives. So what I hope you'll take away from this idea is that it's really important to think holistically about how we can both prevent and reduce disconnection. So at Social Health Labs, we have been leading an event series called Connect Plus Conversations to really explore opportunities to do just that, to prevent and reduce disconnection across those different levels and also in different sectors. So thus far, we've looked at opportunities to prevent and reduce isolation and loneliness in workplaces, cities, schools, and the healthcare system. And in upcoming sessions, we're going to be looking at the role of technology, government, and individuals. So all of the recordings for past sessions, as well as summaries of the takeaways, are available on our website if any of those specific topics are of interest to you. And you can also register for our upcoming events on the website. So now let's dig into some actual examples of initiatives that are going on across all those levels in those different sectors. And I'm going to share examples that are specifically tailored for older adults, but also examples. Oops, I think my slide. Oh, there we go. Sorry about that. There we go. Now it's up to date. So I'll also give examples of people of different ages, because I think it's really important. And I think it was Deb who mentioned that isolation and loneliness are actually most common among younger generations. And while today's panel is about kind of aging in general, we don't start aging once we get old. We start aging once we're born. So I think it's also important to think about this topic across the whole lifespan. So with that, let's dive into some specific examples. So at the global level, there is the Global Initiative on Loneliness and Connection, which is kind of a coalition of organizations that are convening to collaborate, share learnings, and drive forward solutions. The members of this coalition are from the US, Canada, UK, Japan, Germany, and other countries. So it's really exciting to see that this topic is being taken seriously at an international level, and that kind of collaboration and insight sharing is beginning to happen. Another example at the international level is the World Health Organization, which has started focusing on this issue. They will actually be presenting on their work at Connect Plus Government, which is taking place in December. But at a high level, they're really kind of focusing on synthesizing the evidence on solutions and then making recommendations for ministries of health. Another example at the global level is the Togetherness Hub, which is an online community of people around the world who are working in this space. So you can see on the slide an image that indicates kind of the number of people in different countries and different regions around the world who are participating in this community and connecting and collaborating. So that might be something that's of interest to everyone here today. So then at the national level, I'm very happy to share there's a lot going on and a lot of progress being made, which has certainly been re-energized due to the pandemic. So the first example is Commit to Connect, which is an initiative led by the Administration for Community Living that includes developing a clearinghouse for programs, services, and other resources so that people can go there and search for opportunities for social engagement that are right for them. Another thing they're leading is the nationwide network of champions, which again is kind of like a peer network for individuals and leaders across the country who are dedicated to addressing social isolation and loneliness. And second example here is Connect to Effect, which I am going to leave to Paolo to describe because he will be speaking next from the AARP Foundation, who's leading this initiative. But I will just share that one thing I love that they provide is actually an interactive mapping tool where you can look at the data on social isolation among older adults across the US, which is really, really neat. A third example in this space at the national level is the Coalition to End Social Isolation and Loneliness. They are convening stakeholders and really advocating for policy solutions. And some of their partners include Meals on Wheels, Humana, Lyft, the American Psychological Association, and more. And they also host an annual action forum that brings together a lot of people in this space to share insights. A fourth example at the national level is Far From Alone, which is a campaign that is promoting awareness and sharing resources for people who might be experiencing isolation and loneliness. And their partners include us at Social Health Labs, also the Milken Institute, the National Alliance on Mental Illness, Google, Nextdoor, and so on. So again, we're seeing that there are so many cross-sector organizations who are recognizing that this is an issue and coming together to develop solutions. And then finally, the last example at the national level is federal legislation. And there have actually been several bills in recent years focused on this topic. The most recent and perhaps the most exciting of which is the Addressing Social Isolation and Loneliness in Older Adults Act of 2021, which is called SILO for short. So this was included in the Elder Justice Act of 2021, and I believe it's been incorporated into the infrastructure package that we're all talking about. So definitely something to pay attention to. This bill would dedicate $250 million in funding to address social isolation and loneliness among older adults. And it actually requires the Secretary of Health and Human Services to provide grants to community-based organizations who are doing the hard work of implementing these programs and solutions. So definitely something to keep tabs on. So next at the state level, the example I'll share is the Massachusetts Task Force to End Loneliness and Build Community, which I've had the honor of being part of for the last nearly 2 years. This is a coalition of over 30 organizations, including local governments, retirement homes, universities, and nonprofits across the state who are coming together to really collaborate and share learnings on this issue. So some of the activities that we've led thus far include publishing reports, synthesizing different recommendations, hosting statewide summits, launching a campaign called Reach Out MA in partnership with local mayors and community leaders, where we actually shared videos and tools for individuals on local cable stations, as well as in partnership with Comcast. And then we also have different committees that are focused on issues like bridging the digital divide, which I appreciated that Namki brought up, as well as fostering intergenerational connection. And we're starting to see other kind of statewide coalitions like this emerge across the country. So next, we're kind of zooming down on the lens, going through that framework. Now we'll look at the city level. So one example that I love is the Community Living Campaign, which is a nonprofit in San Francisco serving older adults and people with disabilities. And I've had the honor of being on the board for the past 4 years. One of our programs is called Community Connectors, where we actually provide over 100 hours each month of virtual and in-person activities and outreach that are all kind of geared at turning strangers into neighbors and neighbors into friends. And we found a lot of success with this very grassroots localized program. 93% of our participants report feeling less isolated as a result of it. Another kind of similar example of a nonprofit is Friendship Works, which is based in Boston. They similarly have some amazing programs to support older adults, including a friendly visiting program where they match individuals to isolated older adults for regular conversation and companionship. And I'll just take a moment to note here that there are nonprofits like these in every single city across the country. So if you're a local reporter and you're looking for a local story like this, I guarantee you that if you Google around, there are programs and nonprofits like this near you. And then the final example I'll give at the city level is mutual aid groups. This is actually something I hadn't really heard of until the pandemic. And I think many of us have seen these rise up in prominence. But these are essentially local volunteer networks for people to really mobilize support for each other to match needs with skills and different resources. And so we've seen this emerge as a way of supporting isolated older adults, especially during COVID. So finally, at the individual level, the example I would love to share is the monthly microgrant winners. Through my organization, Social Health Labs, we give out $1,000 each month to an individual who has an idea to connect people in their local neighborhood. So you can see we just launched in January, and you can see some of the award recipients here. So some of the examples of the projects that they're leading locally include things like creating a shared community garden, hosting craft making gatherings for people outdoors, making supportive cards for kids at the local hospital, and building a picnic table and benches in a public space for neighbors to gather. So what I love about this and why I'm so inspired by these different individuals is that it's important to recognize that while we need to be focused on these high level kind of systemic opportunities where we can intervene through policy and things like that, it's also important to remember that at the individual level, that's where human connection takes place. And there are many inspiring people like this who are taking action in their local communities. So with that, I hope that the takeaway from what I've just shared, which is a lot of information and a lot of examples, is that there's so much going on to address isolation and loneliness and to really promote social well-being among older adults, but also across people of all ages. And I hope that the takeaway, therefore, is that there are many, many stories to be told and articles to be written about these solutions, about what's being tried, about the individuals who are doing the hard work of kind of reweaving our social fabric. So with that, I want to make sure you know that in the handout you're going to receive, I've provided links to every single one of the examples that I've mentioned here. So if those are of interest, you can certainly go there to learn more. And then also feel free to reach out anytime if you have questions about these or need a source or would like an introduction to any of those programs. And with that, thank you so much, Liz, and I will hand it back over to you.
Thank you, Kathleen. That was awesome. And to wrap up, last but not least, is Paolo Narcisco from the AARP Foundation. He will be hopefully giving some more detail on Connect to Effect and some other programs that are producing results. Paolo.
Thank you so much for having me on this particular panel. It's a privilege to be with Dr. Marion, with Dr. Choi, and with Kathleen. I hope all of you are not only informed with the research, but also inspired by much of the work that's being done in the area of social isolation. So really what I only want to leave you to is with two narratives, hopefully here, is that one is to give you enough resources as journalists to see what is actually happening and some of the innovations that are occurring, around social innovation. And then secondly, it's the importance of how social isolation affects people who are actually in the poverty level, which is a mission of the of AARP Foundation. So hopefully everybody knows who we are at this particular point. The AARP Foundation is obviously the charitable arm of AARP. We serve both members and non-members alike. And our goal is to be able to work to end senior poverty by helping vulnerable senior adults achieve economic security and break down some systematic barriers created by discrimination. As I said, it's kind of part of our narrative is that senior poverty and isolation is a particularly growing problem. It affects, poverty affects just things beyond the financial strength and struggling to meet basic needs of food and shelter and care, for instance, that older adults also struggle at a high risk of social isolation, a condition that is really a public health problem. It's akin to smoking about 15 cigarettes a day. I think many of you have heard that stat before. It affects 1 in 4 older adults in general, and this is prior to the pandemic. And then during the pandemic, with a study that was done with United Healthcare and with the National Sciences Foundation, that it affects 2 out of 3 adults in general, and 2 out of 5 low-income older adults. So it's a growing issue, but obviously the pandemic has affected even more. As Cassie talked about, there are innovations that AARP is championing and the foundation is championing, products and services that we built as a team. But again, we couldn't do this without the partnership that we have with many people in the community and certainly many people on this particular panel itself. One of them, as Cassie talked about, is Connect to Effect. It's a great resource for you to hopefully be able to check out, as it is our platform, how we lead the movement to end social isolation in older adults. And we use this as a platform to help us fund innovative concepts, to launch new programs, and to also call attention to kind of public health issues and helping people build the social connections they need to be able to thrive. From Connect to Effect, you could do a lot of different things, for instance, aside from looking for solutions, also is a tool for individuals to be able to look and see their own level of social isolation and what they might be able to do to be able to improve their level of connectedness. So there's a social isolation risk assessment that you'll see actually on the website or on the mobile device to see how you're affected by social isolation, but also how your loved ones are also affected by social isolation and how you might be able to speak to them about their particular issue and get the help that they need to be able to thrive, especially as they get older. From an innovation perspective, there are many ways we are approaching this. As a technologist, I've always been focused a lot on the technology components. We launched Alcove in August of 2020, so right in the middle of the pandemic. There's you hear a lot about the metaverse, heard about this those particular presentations last week, both by Meta as well as by Microsoft and so forth. We've actually been doing that since for the last 3 years now. And we launched Alcove, which is in essence a place for older adults suffering with social isolation in virtual reality. It's a tool that allows for families to be able to connect within virtual reality in the same living room and to actually share experiences together, which improve social isolation in general. We have roughly about 189,000 active users on Alcove today. So it also dispels the myth that older adults are not going to be adopting technologies like VR and XR. They're adopting it very, very strongly at this point, considering we've only been live since August of last year and the product continues to particularly grow. We also launched, right during the pandemic, a chatbot called Connect to Effect. The chatbot helps to, its goal is to help people over 50 get and stay socially connected. We launched chatbot predominantly because we couldn't do things in person during the pandemic. So it's a friendly bot designed to chat with users over text messages. You can use it on social media as well to build habits. As Dr. Choi talked about in her research, a lot of the behavioral activation habits that we try to incorporate into chatbot to help people stay connected, not only with others in their friends and their communities, but to also build resilience, specifically during this particular pandemic. We have roughly about 70,000 folks on the chatbot, of which about 70% of the folks that are on chatbot today are actually low-income older adults. So again, dispelling the myth that older adults don't use technology, they use it very heavily, and particularly even dispelling the myth that people who are in poverty can't use technology. It's simply a matter of giving them access to it. And they'll show you quite well that the adoption of technology is strong amongst older adults. We launched several years ago a program called Connected Communities. Dr. Marin and Dr. Choi both spoke about the need for people to stay connected and the tools that we need to do that, including the ability to access broadband and Wi-Fi. So ARP Foundation's Connect to Effect, Connected Communities itself connects older adults to that are living in affordable senior housing communities to be able to stay connected with each other and to be able to get community resources and information. They're primarily doing that using Alexa and Google Voice as tools. So literally just talking to Alexa or asking Google. And that is a voice prompt that helps them to be able to stay connected. The program also helped older adults get access to the internet and to Wi-Fi by providing those needed resources in the senior housing communities. Roughly, we have about 56 active senior older communities, low-income older communities that are connected on Connected Effect using the services and supported by many of our partners on the ground. As Kelsey said, it isn't for folks that are on the ground. You won't, these won't succeed at the very end. So in connected communities, there's several features that can use. Many of the communities prevent and promote events, and many of these events became virtual events during the pandemic. There's obviously announcement, community news, helping people stay together, connected together with virtual Bible studies, virtual book clubs, you name it, because many of the seniors who were living in senior living facilities had to actually stay, were even more isolated by having to stay in their apartments and not be able to access all the community services that are normally available for them. Also, as Cassie said, you can find this on connecttoeffect.org, and if you go to the map, we launched this in partnership with the University of Chicago North just a few weeks ago, and also with the generous help of United Healthcare Foundation. It's a social isolation map. And in essence, it's a tool to help visualize social isolation amongst older adults. It's about as simple as we can make it from in terms of describing it. If you use a particular tool, there's different layers that can use, and it's primarily meant for researchers to help identify, but it's also very helpful for communities to be able to understand how social isolation specifically affects them within their specific community and going down to their county and so forth. You can layer the map in, and it will help you to be able to see all of the different risk levels of social isolation. And then you can drill down on all of those different risk levels. You can change the base layer maps and the overlay layers to be able to view the particular data by county and view it also by state level if you wanted to zoom out to a state level perspective as well. And obviously, lastly, you can overlay this even more by looking at how it looks from a national perspective, and also looking to see how it relates to other crises that are going on, including things that are being driven through COVID-19. So the map was just launched. I would encourage hopefully many of you to be able to look at the map and helps visualize kind of how that looks for the entire, how social isolation looks for the entire United States. Again, this is not a consumer tool. This is a tool generally for researchers, as well as for folks that are interested in the issue of social isolation and how they might be able to affect change within their specific community. And then another innovation that we have is the AARP's Experience Corps. This is a community-based volunteer program. It trains volunteers who are over 50 to tutor kids from K to 3 in underserved communities to help them be able to reach third grade reading levels. It is in essence a triple win because it is helpful for older adults, it's helpful for the kids as well as the communities to all grow. And the way this works and why we do this is because we know as seniors age, they're looking for ways to give back and they're looking for ways to find purpose. And Connected Communities gives them the ability to do that by mentoring kids and tutoring kids in schools to be able to help get to reading level. During the pandemic, the program switched completely to virtual because of the fact that many of the schools also moved to virtual. And so our tutors tutored kids to be able to read using the same tools parents use today, like Zoom and so forth, that we're all used to during this particular pandemic. It's a win for the older adults. 98% of the surveyed volunteers said participating in Experience Call helped them to stay physically and mentally active and get a better sense of purpose in life. It's a win for the kids. Roughly about 68% of the kids achieve a third grade reading level at the end of third grade. And it's a win for the communities because research shows that kids who don't get to third grade reading levels at the third grade have a very high risk of not graduating from high school. So again, it's a win for all of the major stakeholders, in the community. Cashley also talked about Commit to Effect. Commit to Connect. Commit to Connect is an initiative launched by the Administration of Community Living and coordinated by AARP Foundation. You're simply just the national coordinators of Commit to Effect to be able to fight social isolation and loneliness by providing resources as a national clearinghouse to see what particular solutions are working and to connect folks with those particular resources to be able to end social isolation and loneliness. Again, it's a nationwide network of champions. It's a great resource to be able to find people who are passionate about the issue, the innovators that Cassie talked about, dedicated to advancing the solutions to end social isolation and loneliness. Hopefully, I was able to give you quickly a very long list of different tools and interventions across a broad spectrum of channels, both in person as well as through use of technology, and also highlight the need for us to also focus on the effects of social isolation, specifically for the low-income older adults. Liz, I'll turn it over to you.
Okay, thank you, Paolo. That was great. So a reminder to everybody that you can type your questions into the chat and I'll get through those, as many as I can. And that our panelists have agreed to hang around afterwards and will be in their separate breakout rooms if you want to do further one-on-one follow-up. But meantime, I wanted to start you all off with a question that I think is really important. What are you not seeing in terms of mental health coverage when it comes to older adults? What headline or topic would each of you like to see reporters have a little bit more coverage on? I'll go down the list. Start with Dr. Marin.
Well, the other panelists get great discussions here. I think the telehealth issue is that, first of all, there's state boundary issues. They were relaxed during COVID, but given the fact that there's a dearth of mental health specialists, and I think what NAMCI is doing is amazing, that to me would be very important. I also know reimbursement for behavioral health services is not good, and people have to pay a lot out of pocket. So I would say that those are the two issues that I think about from a psychiatric perspective.
Dr. Choi?
Yes, I think the digital divide has been really important issues, and we have not done a good job to address the issue, especially during the COVID. So I see mostly among my very low income homebound older adults, the digital divide is still a very, very important issue. So, I mean, you know, this internet connection should be like public utility now. People can't really do anything these days without the internet connection. So I think that the aging service agencies are trying their best. For example, the food stamps SNAP program, if the older adults are on SNAP program, their internet connection with AT&T was like $10. So our case managers were really trying hard to put these people in the SNAP program to get the internet connection. And this should not be the issue in modern day like that. So I would say digital divide is the big issue.
Okay, it's a big one. Kathleen.
Sure. Thanks, Liz. Great question. I think I'll answer it in two ways. The first is that I think the default narrative is that older adults who are isolated or lonely really need our help. And that's true in a lot of ways, but also it's not a very empowering narrative. And there are many older adults who are taking action and doing something about it themselves. And so I think we can simultaneously shine a spotlight on how we can address isolation and loneliness while kind of combating ageism and recognizing that these are individuals with skills, with abilities, with talents, and they have a lot to offer. And keeping in mind that disconnection is often more commonly experienced by youth, by teenagers, by young adults. And so where are the intergenerational opportunities that are emerging, where it's the older adults giving value to the younger people rather than the other way around? So that's the first answer. The second is that I think a lot of the narratives and kind of articles that I've seen emerge have focused on how bad social isolation and loneliness are for us, right? But how detrimental they are to our health and so on. And that's absolutely important to raise awareness. But I think we're at a point now where we can flip the narrative a bit and focus more on how beneficial social connection is and what are all the ways that we can be more meaningfully connected with each other. What are these initiatives that are arising? And hopefully I've made this easy for you and hopefully all of us have by giving you many, many examples to spotlight. But I think really focusing on the opportunities and what's being done and the stories of individuals who are doing something about this and connecting people.
That's a very good point. Very good point. Paolo, what should we be reporting on that you're not seeing?
Yeah, well, I certainly agree with Cassidy. I think we're taking this narrative from really a more positive approach where older adults, as you've seen, even as we launch Alcove and our chatbot, are taking initiative while we are in fact a charity, that's just our structure. We are not designing technologies and tools that are charitable tools. These are tools that older adults are using themselves, finding themselves and achieving the importance of social connection, and they understand that. So also in agreement with Cassidy that I think it's important to be able to, there are a lot of folks working on this issue. And it's important to spotlight all of these different solutions that are out there and to encourage even more folks to get involved and to look for market solutions that help us get people connected versus focusing on the fact that folks are also isolated. And lastly, if I can have three, is the ability to really talk about social isolation also as a fourth safety net. I think we found that in the pandemic, we talked about the safety nets of income and jobs and so forth, but also keeping people connected is something that is crucial for us. And we've learned that in the pandemic, how important it was.
Great. I think those are all really important stories for reporters to focus on. And just a reminder, we will be making slides and handouts available. So anyone that wants to follow up on any of these ideas, you'll have various ways to reach out to our panelists. One question that's coming in is, I'm wondering whether aging in place is a mixed blessing and whether there's a class divide that hasn't been acknowledged in reporting on this subject. Aging in place is great for people with resources and attentive family and friends, but it's a hardship for seniors in rural and sometimes even urban areas who lack those connections and support. Is a better model for social connectedness for lower income people really to find another way to allow them to age, at least in the community, if not in their own home. Who wants to take that one? That's kind of a 5-part question there. Dr. Marin, you want to start?
When people talk aging in place, they often think about actually institutionalizing somebody. I think what this person is more talking about, living in communities. Most of these places that are communities aren't cheap. They're more real estate ventures, excuse my opinion about that. So in many ways, actually, if you can age in place safely, with everything I think you heard about here, I think that is a good solution, because moving is really hard and expensive. So that would be my thought about it, actually.
Anybody else have some thoughts on aging in place versus moving to a more congregate type setting?
Yeah, sorry, Dr. Choi, go ahead, please.
No, I was going to say that, it's a good point. However, the autonomy, the even very low income, low resourced older adults really value their autonomy and independence. So, in a community where they could exert their autonomy and independence, that's a great idea. However, most my low income older adults want to still stay home because of that kind of values, their value of the autonomy.
Paolo?
No, I was just saying that I maybe a different perspective is aging in motion, right? Not aging in place, where and regardless of your socioeconomic levels, being able to have that autonomy requires you to move, not moving to different places, but being able to staying active in your community, being healthy and physically active are all important. So rather than talking about the notion of just stay in your place and create tools that allow you to do that, allow us to be able to interact with folks, to become healthier, be able to do those activities.
And we had another question come in that has to do with seniors or older adults. Try not to use the word seniors because I'm pushing that myself. How they're re-entering the social connectedness in the real world now. A lot of people have stayed away for a year and a half. And a lot of people are fearful now going back out into the world, whether it's going to their senior center or whether it's going to family gatherings, Thanksgiving's coming up. It's almost like they've been away from people so long, it's hard to turn that switch again. So how can we help them kind of overcome those fears while acknowledging them, because they certainly are valid and real?
I can start there if you'd like. So to share an anecdote, my partner's grandmother is 86 years old, the most social person I've ever met, far more popular than me. She gets phone calls all the time. But prior to the pandemic, she was constantly going out and about, very engaged socially in the community. And the pandemic has actually been an opportunity for her to reflect on those preferences and realize that there are actual benefits to being able to connect remotely and join her church service over Zoom instead of the energy that it takes to go in person. And so I think I also want to recognize in this question, Liz, is that there is a blessing in this as well, which is that perhaps we don't need to be going out all the time. It's really more about focusing on quality interactions rather than the quantity, and taking care of our social needs in different ways. That doesn't mean that you have to go out and socialize all the time, although that's obviously important sometimes, but it's also about, just prioritizing all of your social needs, which include time alone and time to recharge.
Good point. Anybody else want to chime in?
Just to chime in again, I think the perspective is different depending on who we are also. And one of the areas that I'd like to highlight are specifically, as we've seen with Asian Americans during the pandemic and with a lot of the anti-Asian hate that occurred, where many, specifically, Asian older adults, and I know I'm generalizing a little bit, are actually still fearful about leaving their homes because of a lot of the things that have happened. And so I think it's important for us to also look at this issue from an issue of race, ethnicity, and inclusion to help folks who potentially don't feel like they belong anymore to be able to reintegrate back into social connections. So just a different perspective, just depending on really which part of the population we're talking about.
Thanks, Paula. Good point. I have a question for Dr. Marin, which you mentioned earlier, two things. One is the cognitive decline that can come with isolation. And the second was the fact that a lot of the family caregivers are also struggling. So part one of the question is, can some of that cognitive decline be mitigated once people start going out and interacting and getting those connections again?
It's complicated. In that there's cognitive decline that's, really biological, and it's very hard to reverse some of that. But there's also just kind of like, if you will, cognitive like not being stimulated and kind of forgetting to do things that you could do, and practicing can really help. I mean, people, for example, may know how to play canasta very well. They haven't played in a while, they feel a little rusty, but they know how to play canasta. The cognition is still there. So practice is very important. And there's some general, like I call it the secret sauce, if you will, of preventing cognitive decline, which is, making sure at all ages that we eat correctly. I think nutrition risk is an issue for cognitive decline, particularly in social isolation. We have to look at that in poor communities. Good nutrition, check B12, check vitamin D. Exercise is very good for the brain. So re-engaging in those or starting those activities. And what I really like what these guys are talking about is connecting with other people to do these things. There's no question that actually exercise twice a week can help mitigate some symptoms of depression. So, and depression and cognition are connected, by the way. I think Dr. Choi can talk about this too. A lot of people, when they're older, they're not dementing, they're depressed. Mm-hmm. And that makes them look like they have a cognitive decline.
And as far as reaching out to the family caregivers who are also struggling, a lot of times I talk to caregivers and they say, oh, I don't have time for that. I'm too busy taking care of mom. I can't worry about myself, whether it's their mental or their physical health. How can we stress the importance that they need to take care of themselves first?
Self-care is, if you don't take care of yourself, it's going to be nigh impossible to take care of others. And I give an example like self-care, because I give a lot of talk on this stuff. It's like, why don't you make sure you get off the subway one stop early? You can walk the 10 minutes. You're worth it. Find a way with smart activities to do a little bit. Don't expect everything, but start something. It's really important.
Great. Dr. Choi, did you want to chime in on the depression?
Yes, depression is really cognitive kind of manifestations. So I think we always say that some older adults that my memory is not good. I think I might have something. And I said, okay, let's try depression treatment first. And most of the times, that they get better. So I think that depression treatment is really, it's really double benefits to help them overcome their depressive symptoms, become more active, behavior activation, and also helps them to have more confidence in their cognitive capacities. So yes.
Thank you. Cassie, in the UK, they've actually delegated a ministerial position called the Minister of Loneliness. Do we need something like that here on state or federal level?
It's a good question. Actually, Japan followed suit earlier this year, and they now also have a Minister for Loneliness. It's such an interesting question. So I think that the government's role in an issue like this is twofold. One, it's legitimizing the fact that this is a very important issue that we need to be paying attention to. It has an outsized effect on people's health. We need to take it seriously. And the second is to support solutions, right? And that could be through funding them, or that could be through leading them. So like you said, Liz, the UK and Japan have taken this approach of leading them. And the UK in particular, since they have a few years head start, has developed a really comprehensive strategy. I don't know that it's linked in my resource link, but I could dig it up for anyone who's interested. That really engages a lot of different stakeholders in how all of the UK can approach this issue. That said, it's not clear what kind of the measurable impact of that is, and it might just be too soon. It's also a really thorny thing to sort through and figure out. So I'm really curious to kind of follow along in the years to come to see where that leads, and does it measurably reduce levels of loneliness in the UK society? I think in the US, there's so much good work being done, which I hope I've highlighted in my presentation. And so I think the government's role is really in supporting that further and energizing that. And I think that if we do appoint a dedicated role or a team, it shouldn't be called, for example, the Secretary of Loneliness. It should be called the Secretary of Community or the Secretary of Social Well-being, something that really underscores that this is beyond just individuals who are currently feeling isolated or lonely. It's really something that all of us need to pay attention to. We all need to nourish our relationships and ensure that we feel engaged in our local neighborhoods and things like that. It's essential to all of our health and well-being. So while it's kind of two sides of the same coin, I think that framing for a role like this means that their leadership could be that much more effective. And also the last thing I'll say is that if we were to do something like that, it would need to focus on all ages. Obviously, the legislation in the US that's been put forth so far has focused on older adults, which is very important. But like we've mentioned several times, this is relevant across the lifespan.
Excellent.
I do want to say one thing. This is not an expensive date, guys. You know, I think if you look at the return on investment for what Dr. Choi has talked about, for example, and that's probably the higher end, actually, to have these lay health counselors. This is not like getting MRIs. I really think we have to sit back and say, wait a minute, you can get so much for these inexpensive things to occur, to mobilize people. And it's patently obvious,
It seems obvious to us, but when we get into policy issues, everybody's got their priorities. Paolo, I did have a question for you, but I'm getting the signal that we're wrapping up. So I'm going to ask it to you in the breakout room. I want to thank all our panelists for a wonderful discussion. I personally learned a lot, and I have at least a half dozen story ideas here to follow up. I hope everybody else does. And thank you so much for starting off our mental health workshop with such an awesome presentation and some really great information. So just if you bear with the control room, they'll put you into your breakout rooms. And thank you again for all your time and energy today.